welcome back to another episode of the Core Consult RX podcast. Cole, what's going on, man?
Dude, I am melting over here completely
because of the this very mild summer that we're having.
It's crazy.
Yeah,
I live in constant
concern
that my AC is going to go out because a lot of people I've known it has gone out, and it just seems like something that would happen to me. So
yeah, that'd be no good if it happened right now. I actually just had my whole unit like replaced just recently, so I'm not worrying about that at all this summer.
Yeah,
knock on wood.
Mine's at least,
say that it just blows up tomorrow.
Mine's at least 10 years old.
Yeah, that's about the time.
Yeah, it's crazy. I will say, I've just moved a little bit west of Charleston where we were. In humidity, we joke about the dry heat like out west and stuff, but having a lower humidity makes a huge difference in terms of how wet your shirt gets while you're outside,
Oh, for sure.
And yeah, I mean, it's super hot no matter what. It's super hot, but I do definitely sweat less than in Charleston.
Yeah, it's terrible. Like walking from the parking lot area to the clinic right now is like, I've been bringing an extra shirt like in case I have to park like further out. And yeah, like even in scrubs, I'm like, geez, this is terrible.
So one thing that Anna asked me to do before our baby was born was to get the garage cleaned out so that she could get her car in there, so it stays cool during these hot days. And I didn't quite get there. So sadly, her car is still out in the heat. So she has to crank it like 20 minutes before she puts the baby in there because of how hot it is.
That's perfect. Chivalry's not dead, right?
Yeah. Yeah. I'll get to it
I'm just kidding. Yeah, I would have said the same thing. It's, all right, I'll do it. And then I'll forget about it for 4 weeks.
I did try. We just have a lot of junk in our garage. Yeah,
because we're busy. Or who knows, maybe we're even fighting a skin infection. Because that's what we're talking about tonight.
Yes.
That's my segue.
That's great.
We've been talking for 5 minutes. Yeah, thanks. But we don't have skin infections, by the way. We're fine. But skin infections, skin and soft tissue infections specifically, kind of going through the purulent, non-purulent infections and discussing some of the differences in treatment. And this will be an accredited episode thanks to our friends over at freece.com. And for all of you listeners out there who are already members of FreeCE, you basically get this included in your unlimited membership. Also, all the episodes we've done, they're accredited. And at some point during the episode, we will give you a super secret password. And once you finish listening, use that password to access the post-activity quiz, exam, whatever you want to call it. I never know what to call that every week. But
I think quiz is good.
Quiz is good, okay. It'll be on FreeCE's website. Go to Learn, and then you'll see the different platforms that they have, like monographs, and you'll see podcasts. Pick this episode, use that password, take your test, get your 1 hour of continuing education credit for pharmacists and nurses. If you're not a member of FreeCE, definitely check them out. They have all kinds of excellent learning opportunities on the website. So make sure you give that a look, and thanks to them for partnering with us.
Yeah, for 10-ish multiple choice questions, if I was given that in class, I'd call that a quiz, an exam.
Somehow I knew in my mind, even though I was talking, the back of my mind was thinking, I was like, I bet you Cole's still caught up on the fact that there's no way it's an exam because there's not enough questions.
I'm sure there's another word for it.
Quiz seems like not like, it seems like you shouldn't be getting credit for a quiz.
Yeah.
So it's like we got to find something in between there.
Yeah.
I don't know.
We'll think on it.
Certainly doesn't matter. That's for sure.
Maybe ChatGPT can give us some other synonyms.
Yeah, probably.
Yeah.
That's how I live my life now. All right. So talking about skin and soft tissue infections, we can kind of subcategorize those into, like I said, non-purulent and purulent. So from a non-purulent standpoint, and what we're going to kind of focus on first, as far as going through the treatments and everything, the non-purulent skin and soft tissue infections can include, commonly cellulitis, as well as erysipelas, which is it's a more superficial, sharply demarcated version of cellulitis, if you will, whereas subcutaneous is deeper into the skin, more into the subcutaneous layer. Both can be caused by group A streptococcus, so strep pyogenes. Other strep species can also cause that type of infection as well. And, in some very severe cases, the patient can actually end up having, necrosis as a result of the infection. Typically in that setting, there may be more harsh bugs, hardcore bugs, whatever you want to say, that are actually causing it. So, the causative pathogens may be more diverse, I should say. So anaerobic pathogens can be a culprit. Clostridial can also species can be a culprit as well. There's also just patients that end up getting polymicrobial infections, and end up needing to be treated in a more broad spectrum regimen. Necrotizing fasciitis is obviously the most severe, result of one of these infections, but it's in the deep soft tissue, and that's basically resulting from the progressive destruction of the muscle fascia and the overlaying subcutaneous fat. So in that case may include surgery and some of hardcore antibiotic regimens. But kind of the breakdown of that, and then what we'll do is we'll kind of work our way through the algorithm of the various treatments, and then talk about the antibiotics to use this as a good time to kind of review some of our clinical pearls. But before we jump into that, Cole, do you want to break down the purulent infections?
So there's some specific types of purulent. I cannot say that word, by the way. I'm just going to go ahead and say that. Purulent SSTIs, and one would be a cutaneous abscess, which would be a collection of pus within the dermis and the deeper skin tissues. If you ever had to experience this in a clinical setting, depending on the location, it can be pretty gross and can be extremely painful when they have to incise and drain it. And then there's also everybody's least favorite uncles, the furuncles and the carbuncles. A furuncle is kind of what's known as a boil. It would be an infection that begins at a hair follicle that eventually becomes an abscess, and it can drain spontaneously, or it can drain because somebody intentionally drained it. Often that's caused by MRSA. The carbuncles are like a family reunion of furuncles, a grouping of a bunch of them to form a single inflamed area, also often caused by MRSA. Have we talked about this recently where I asked if you've ever had a MRSA infection? I feel like we did.
I don't know.
Maybe not.
I mean, I'm sure we have at some point.
Because I feel like it came up that it was going around my, like when we would, had football practice, just, you never wash your practice jerseys. And so I remember the only time that it prompted us for everybody to wash them was when somebody had a MRSA infection.
Yeah, no, I had, I got one on my, the back of my leg or something like that from wrestling mats. And, I've had it where you get the nasal carriage and, things like that where I could tell, but my both nostrils are both scabbed horribly up and stuff. But I've only had it a couple times, and it was never bad where I needed IV antibiotics or anything like that. It was Bactrim, and it was good to go.
Yeah. Yeah.
So, yeah, but purulent SSTIs, the breakdown that you said, you mentioned the everybody's favorite uncle. I don't know what it was about furuncles, carbuncles, and all that. Just the fact that whole skin and soft tissue infection just confused me to no end when I was in pharmacy school. Because I remember being just mad that they named something because I was just tired of studying. I was like, this is furuncle? What a stupid term. Just having a 22-year-old meltdown in the library.
So frustrated at the terminology, you couldn't even memorize it.
I couldn't even memorize. I was so mad. But obviously, like Cole said, the purulent SSTIs are more associated with MRS or Staph aureus and potentially even MRSA, but there are certain situations, certain risk factors that someone may have to where the species can be outside of the norm, and not just strep pyogenes for non-purulent and strep aureus or Staph aureus rather for purulent. If the patient has certain situations in which they were exposed to the pathogen, the certain comorbidities, things like that, then that may push you in one direction over the other. So to give you an example, a patient with cirrhosis is going to be more likely to having a cellulitis infection that is due to a gram-negative bug like Klebsiella or E. coli, maybe even Aeromonas. If somebody has a cellulitis infection and they were recently in fresh water, a lake, a river, Aeromonas is definitely a very commonly thought of potential pathogen. And then a couple's like Pseudomonas species, things like that, can also be considered. But Aeromonas, I feel like, is the big one when you're thinking of fresh water. If the patient, has been in salt water, we may think of a Vibrio species as being the cause of pathogen. If it's a patient who was bit by something, especially, animal bite, especially human bite, we have to worry about anaerobic bacteria being the cause, and so on and so forth. A nail puncture through the sneakers, we think more Pseudomonas. So there's definitely some things that can, point us in one direction or the other as far as like the empiric therapy, or at least the direction that we think we're going to end up having to go with treatment. But above all, everyone should be receiving, at least their strep coverage, staph coverage if it's purulent, and going from there. But we'll start off with the algorithm for the non-purulent infections. And so we'll kind of go through the treatment options kind of as a whole. And then, like I said, we'll use this time as a good opportunity to review some antibiotics and things. So we'll start off with, the non-purulent algorithm. There's several different versions of it. They're all pretty much the same. Some are just a lot more in detail than the others. So for like reference, we're looking at the up-to-date algorithm as well as the 2020, I think it's 2020 guidelines, and a couple others, but I can link that in the show notes. But okay, non-purulent infection. There are, like I said, certain things we would start to move towards maybe a specific management. So if, like we went through those different scenarios that the patient may have gotten the infection, we may be thinking of a certain type of pathogen. The other thing we need to consider is, does the patient have signs of like severe sepsis? And if we're thinking sepsis, we're thinking hypotension, septic shock. We typically manage these patients as toxic shock syndrome patients, and so it's something that we go a little bit more intense with the medication regimen. But if they don't have any signs of sepsis, then it becomes, evaluating the patient for parenteral antibiotics. So do you think you need to actually admit them to the hospital in order to, get to get treatment, or can we use something with similar coverage in the outpatient setting? So some of the things to keep in mind, when you're assessing this, risk of whether or not you need to admit or not. If the patient has signs of like systemic toxicity, so if they're feverish, if their fever is 100.5 or more Fahrenheit, 38 degrees Celsius or more, with sustained tachycardia, that can be some symptoms, obviously, of a toxicity going on. If there's rapid progression of erythema, extensive erythema present as well, it can also be a sign that maybe this infection's a little bit more intense than we would assume. Inability to tolerate or absorb oral therapy is obviously a big factor that we'd have to consider, and if they can't, we would need to admit them. If no, you can kind of check the boxes off for no, and in that category, and basically say we're going to discharge the patient with oral medications. The last little thing that we have to look at is there a chance the patient could have the infection being caused by MRSA? So like, do we need to actually have MRSA coverage? If the wound was purulent and things, that would obviously be a whole different scenario. But certain risk factors, like if the patient is an injection drug user, that can potentially put them at higher risk. Recent hospitalization, if they've had recent surgery, if it's a patient that resides in a long-term care facility, if they're on hemodialysis, and certain socioeconomics things like homelessness is going to increase the risk for MRSA. If the patient also has comorbidities like HIV, if it's a patient who was recently incarcerated or even working as a prison guard, if it's someone who lives in very like crowded conditions, dormitory type living quarters, then that can also put them at risk. And if they do have risk factors and we want to cover for MRSA, we're still going to cover for strep because that's the most causative pathogen. But we would just increase the spectrum of activity, if you will. So instead of using some of our beta-lactams, which is what we would typically use if we're not worried about MRSA, we may have to use things like oral Bactrim or clindamycin, even linezolid maybe. But if we're not worried about MRSA, and for a lot of these patients we're not, we're just trying to worry about the strep coverage. If we're not worried about MRSA, then we typically will just give a beta-lactam that targets beta hemolytic strep, as well as covers for Staph aureus. And so dicloxacillin, cephalexin, cifidroxil are all potential options. Obviously those are going to have more narrow spectrum and they're not going to have MRSA coverage. But obviously if the patient doesn't need excessive coverage, we always want to be thinking about antimicrobial stewardship and, obviously not getting the patient in increased risk for resistance as time goes on. So that's, again, on the side of things where there's no severe sepsis present, and also there's no concern for like MRSA or anything like that, then we're just using our basic beta-lactams that have that strep and staph coverage. If we need to give outpatient, but we're basically having to use MRSA coverage, then we're thinking along the lines of like Bactrim or linezolid, clindamycin, things like that. Now, if the patient does have an indication for parenteral antibiotics, so they need to be admitted, the coverage is kind of the same as far as the empiric therapies go. It would just be instead of the oral version, you would use the similar IV formulation. So like cefazolin for your cephalosporin, nafcillin, oxacillin for your penicillin derivatives. If the patient has a true like severe penicillin allergy, anaphylaxis, something like that, vancomycin could potentially be an alternative to that. And if you have a patient, again, who has risk factors for MRSA, you still have to keep that in mind when you're selecting therapy. And in that case, if you have those more rare instances where the patient has these risk factors, then you would jump right to vancomycin and not even worry about the cefazolin or oxacillin. And then another alternative, potentially, at least that the up-to-date authors include, is daptomycin is another alternative. But again, that's only if you are worried about MRSA specifically.
Right.
If not, we don't need the coverage.
Right.
Sorry, that was it took me longer to get to that algorithm than I thought. I was just rambling.
No,
Sorry,
that was
man.
good.
Left you hanging.
That was a good summary, I say.
Oh, hey, thanks.
Yes. So thinking about non-purulent infections, you can kind of think of mild or moderate, and that's going to steer our decision making in terms of which antibiotic to use. If it's mild, we're kind of thinking strep pyogenes. Oral antibiotics are probably okay here, like penicillin or amoxicillin, cephalexin, dicloxacillin, clindamycin. These are all fine. In a moderate situation, then we're thinking similar medications, but IV versions, penicillin, cefazolin, ceftriaxone, nafcillin, and clindamycin as well.
Yeah, and I guess we can kind of just jump into some of the review of the antibiotics since we've just rattled off like 7 classes of them. But we'll start off with the beta-lactams because remember, beta-lactams include the penicillin derivatives, the cephalosporins, and the carbapenems. All of those are going to be considered time-dependent killing properties, and mechanistically they're all working around the same mechanism or pathway, which is where they're inhibiting the enzyme penicillin binding protein, which is what's basically responsible for that cross-linking that forms with the peptidoglycan wall on the bacteria itself. And so when you inhibit that, obviously it stops that formation of that peptidoglycan wall, and hopefully the bacteria ceases to be after a while.
Yeah.
Anytime we're thinking beta-lactams, adverse effects, always thinking GI problems. That's a huge issue with these. The augmentins and stuff, especially the more broad spectrum agents, definitely have a tendency to tear your stomach up. So making sure patients are taking them with food if possible. It's also a very, very common class of medication for patients to have allergies to. Now, oftentimes those allergies are a rash, but it's a very common, even mild allergy that a lot of patients report. Certain penicillins in particular can increase LFTs, usually like nafcillin, oxacillin are some of the more likely culprits. So, if you have a patient that you're going to be, especially on high doses, and if it's going to be a longer duration than, maybe normal, we would want to make sure we're monitoring LFTs. But specifically in prolonged courses, that's going to be more important than, our short duration infections, like with what we're talking about. Also, some renal dose adjustments to be aware of. If the patient has a creatinine clearance less than 30, the big one I always kind of keep in the back of my head is that I'm trying to avoid the amoxicillin 875 dose. So if you need to do a dose reduction down to the 500, then that may be warranted if that patient shows up with chronic kidney disease. And then nafcillin, oxacillin, while they can increase your LFTs, they also don't need to be renally dose adjusted. So that's some benefits to those two.
Yeah. Then thinking about the cephalosporins specifically, a few pearls like cefuroxime and ceftonir can have some issues with acid-reducing agents, so you'd want to separate them from an antacid by 2 hours, and you want to avoid their use in a patient who's using an H2 blocker or a PPI. Adverse effects are going to be what's mentioned: GI upset, rash, increase in LFTs. And then, of course, the penicillin allergy always comes up and, isn't a guaranteed concern with a patient who has a true penicillin allergy. There's only about maybe a less than 10% even cross-sensitivity with the cephalosporins. Some things to consider are certain cephalosporins and their penicillins have identical side chains, like cefadroxil, cefprozil, and ceftriaxone share an identical side chain with amoxicillin. And then with ampicillin, there's a few that have identical side chains, like cephalexin, cephedrine, cefaclor, have identical side chains to ampicillin.
Yeah, and we'll finish up talking about the antibiotics, but remind me to go back. I want to make sure I say one thing about the patient. If they do happen to have severe sepsis, there is also an empiric recommended regimen for that. So I want to make sure I go back to that. But let's finish talking through these. So clindamycin, we mentioned that is another potential alternative to the beta-lactams. Clindamycin, been around for a long time, definitely has great strep and staph coverage, including MRSA. It does not cover enterococcus, however, which obviously is not going to be a concern here. Mechanistically, it is binding to that 50S ribosomal subunit, so you're inhibiting downstream the RNA-dependent protein synthesis, interrupt that process, and obviously the bacteria cannot thrive. It does carry a box warning for increased risk of causing a C. diff infection. And I'm pretty sure we've talked about this before, but if you look statistically now, there's other antibiotics, other classes that are actually more commonly causing, or at least thought to be the cause behind a C. diff infection. But that's really just because clindamycin is not used nearly as often now as it once was. So that's not to say that the C. diff infection risk is not, still something you should be concerned with. For an otherwise healthy patient, it may not be a big deal, but, you have a patient who's residing in nursing homes or on long-term PPIs, things like that, then may be something we watch for.
Right.
But does still carry that box warning.
Right. So all of these have been related to mild or moderate. If we're thinking severe, then kind of like we've mentioned, you're thinking of IV antibiotics. But how do you determine if it's a severe non-purulent infection? If they've failed oral antibiotics, it would be considered severe. Immunocompromised patients, presence of skin sloughing, hypotension, end organ dysfunction, or if they have systemic inflammatory response syndrome, which would be 2 or more of either a temperature greater than 38 degrees Celsius, pulse greater than 90 beats per minute, respiratory rate greater than 24, or white blood cell count less than 4,000 or greater than 12,000 would classify them to have SIRS. And in any of those instances, that would be considered more severe, and we have to use more significant antibiotics.
Yeah. We also, if it is classified as a severe non-purulent infection, then we would also want to assess for the potential for necrotizing infection. So we would want to get a surgical consultation to assess the patient for possible debridement. We would also do an imaging assessment in some labs, so we can kind of look for signs of necrotizing fasciitis using a CT or MRI, and then also obviously looking for things like an elevated white blood cell count, especially if it's more than 14,000. If the patient has an elevated BUN level, possibly greater than 15, and as well as reduced serum sodium levels. So it starts to fall below 135. That also may be concerning. So if that is the case, and if the patient is found to have necrotizing fasciitis, we're jumping right to big guns as far as the antibiotics. So we're going to give vancomycin for one, and then we're also going to add on to the vancomycin piperacillin, tazobactam, Zosyn. So another beta-lactam with a beta-lactamase inhibitor, a very broad spectrum antibiotic on board as well. And so if the patient comes back, culture and sensitivity reports comes back, and it's a bug that is very susceptible to a much more mild regimen, by all means de-escalate the antibiotics. But that empirically would be the route to go if necrotizing fasciitis is the result of the infection getting so severe.
Right. So thinking through some of the drugs, we'll review them, though we've talked about them before. Vancomycin, a glycopeptide, has good coverage for MRSA, streptococci, enterococci, except maybe VRE and C. diff if given orally. It inhibits bacterial cell wall synthesis, does have side effects associated with it, like possibly ototoxicity, possibly nephrotoxicity. It can cause infusion-related reactions, like red man syndrome, phlebitis as well. And it does require monitoring. It has renal dose adjustments with chronic kidney disease. This is what is going to be regularly monitored in patient to get vancomycin trough concentrations. The troughs are generally drawn before the 4th dose. The goal is typically 15 to 20 micrograms per milliliter. And vancomycin would be considered a first-line treatment for MRSA infection. But you need to use it with caution if a patient's taking other nephrotoxic drugs like cyclosporin, loop diuretics, NSAIDs, anything that could affect the kidneys. You'd want to use caution and monitor closely for that.
Hey guys, I'm sorry to interrupt the episode, but I wanted to tell you briefly about our sponsor, Freed AI. Do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you are shaking your head yes, keep listening. Freed is an AI scribe that makes charting go away. It does your notes for you. Freed listens, prepares your notes, and writes patient instructions. Charting is done before your patient walks out of the room. Freed learns your style over time, just like a human scribe would. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. You can try 10 notes for free, and after that, it only costs $99 per month. You can find out more information at their website, www.getfreed.ai. Check them out today. Back to the show. Yeah, and I mentioned with covering for MRSA for the more severe patients that are being treated in the hospital, that daptomycin was one of the alternatives for vancomycin if somebody had contraindication or an allergy to vancomycin, they listed daptomycin as a potential alternative. So daptomycin is a cyclic lipopeptide. It also has fantastic coverage for MRSA and strep, as well as enterococcus. And like Cole mentioned, the VRE species, the daptomycin typically does have coverage for that as well. So if that was a concern, obviously with having vancomycin as typical first line, then that may be another reason to move to dapto in other situations. Mechanistically, this is working by inhibiting the intracellular replication processes, so protein synthesis, being a big part of that, and eventually these biological processes being interrupted results in the bacterial cell death. Some kind of unique, I guess, side effects to this, or potential warnings to things to monitor, would be they can cause myopathy, as well as rhabdomyolysis in some more rare cases. And so if the patient is going to be on this for an extended period of time, probably won't be an issue for something like cellulitis, as long as we're obviously getting the infection to respond to the antibiotics. But if they are going to be on it long term, with daptomycin in particular, they would want to monitor CPK levels weekly. It also can cause a falsely increased INR reading. And so if you have a patient who's happened to be on warfarin, make sure that you note that their INR may not be accurate while they're on the daptomycin. It does not actually increase the bleed risk, though. So it's falsely increasing the INR, but that doesn't actually mean that the patient's more anticoagulated.
Right.
And this is just a fun, like, clinical pearl, just because I feel like every time I hear the word daptomycin, this always comes to my mind. But in certain situations where we're trying to cover for MRSA, like in pneumonia, I feel like a good, like, NAPLEX type question is which of these drugs could we use to cover MRSA, in the lungs that's causing pneumonia? And daptomycin is always the wrong answer as far as potential treatment options, because the surfactant in the lungs messes up the structural integrity of the daptomycin, and you can't use it. And so that has nothing to do with what we're talking about. But in case any of y'all are studying for boards or tests or whatever, maybe that'll be helpful.
Or if you're going to a restaurant doing some trivia and trying to win a nice little prize.
That is true. Although I've never been to a trivia night where they gave me daptomycin as something I had to know about for that night.
I think I went to a medical trivia thing one time. It wasn't all drugs or anything, but I think it was mostly like medical related questions. It was fun.
It'd be cool. Just a bunch of nerds playing.
Yeah.
Even more nerds than usual.
Yeah. Because usually trivia is all very cool cats.
Yeah, I was going to say the coolest people ever.
Go to trivia nights and eat boneless wings.
Exactly. You want to go through some of the more like pathogen-specific treatments if we've established a true causative pathogen?
Yes. Do you want to give the password before I get into that?
Oh, yeah, it is about that time, isn't it? So today's password will be SSTI24. SSTI, all capital letters, 24. So go to freece.com's website, put in that as your password to the activity for this episode, and you'll get access to the 10-question multiple choice test, quiz, exam, whatever we're calling it.
We're more than halfway through 2024, right? So we'll be moving on to the 25 on the password soon.
I know. It's crazy.
It's wild. And also, shameless plug for my Google Chrome extension called MedSearch. Just put that into Google Chrome extension, MedSearch. Help you search medical websites faster. Thank you to everybody who's downloaded it so far. Appreciate it.
Have people been checking it out?
Yes. After every episode, a number of people get on it. So pretty cool.
Oh, that's awesome.
Yeah,
Very cool.
Cool.
Have you added anything or done anything else to it since you brought it up last time?
I have in the background. I haven't uploaded any updates yet, though.
Gotcha.
So, yes.
Cool.
Yes.
So 2.0 is coming out soon?
It'll come out eventually. Yes.
Nice.
Yes.
Eventually. All right. That's cool, man.
Yeah. Okay, so like Mike said, there are some treatments that would be specific to certain pathogens, depending on what might have happened, or if we've gotten a culture and sensitivity and we know what's going on, we can use specific pathogens. And this is still severe non-purulent infections. So necrotizing group A strep or clostridial infection, you would want to use penicillin G plus clindamycin. If they have Vibrio vulnificus, this may be associated with saltwater exposure. You'd want to use doxycycline plus ceftazidime. If they have Aeromonas hydrophila, which might be associated with fresh brackish water exposure, doxycycline plus ciprofloxacin. Whenever I hear the term brackish water, I always think of my granddad for some reason. I feel like he used the word brackish. He had a house at the lake, and I guess he was always talking about water, though there wasn't salt associated at all. But just the word brackish.
He just liked the word brackish.
Just older Southern guy just liked saying the word brackish.
It is a good word.
It's a good word.
Yeah. I definitely. I'm sure I've used it several times where I'm like, there may or may not be actual mixture of water going on here.
Right.
It's probably just all salt water.
Right. But brackish sounds good.
But brackish sounds like I know what I'm talking about.
Yeah. For those who aren't,
I'm like a marine biologist, basically,
who don't live around salt water. I think it's just like a mixture of salt and fresh
salt
water.
And fresh.
Right?
Yeah. All right. So I know we've just run through that whole algorithm kind of quickly, but to go back to the top, because I do want to mention this too. When we were first assessing, to make sure the patient is going to be treated and, diagnosed with a non-purulent infection. And then from there, we asked if the patient has any sense of like severe sepsis. And so we went through some of those potential, things like we were talking about treating it, like toxic shock syndrome, basically in that case. And so if that is the case, we're obviously skipping the whole part where we're assessing if we're going to actually put the patient in the hospital, because the answer is yes. And we're also going to jump right to very broad spectrum IV antibiotics. So again, vancomycin is up, and then daptomycin is again an alternative. And from there, we are looking at potential add-on agents, even empirically, and so it's either like cefepime would be one option that you could add to the vancomycin or daptomycin. If the patient is just thought to, or at least the infection is thought to be potentially caused by a ESBL positive organism, then meropenem would probably be a better alternative to that. And then if you have a patient who cannot take a beta-lactam agent for whatever reason, then you can give the IV vancomycin plus either levofloxacin or aztreonam. So remember, aztreonam is a monobactam, and so even though it looks, in name anyway, like it would be very similar to the beta-lactams, even if the person has like a really severe allergy to a beta-lactam, they're not going to have a cross-reactivity with them with aztreonam, the monobactam. So that's a potential option instead of the beta-lactam like cefepime or meropenem.
Nice.
Did that make sense?
Yeah.
I feel like it's so hard to describe this without having a picture to go off of.
It's one of those things.
I mean, I have a picture, but you guys listening don't have a picture.
You painted a nice one, I think.
Oh, thank you.
Yeah. Okay.
Gentle brush strokes.
That all you got with that?
Okay. Yeah. Okay. Go ahead.
So moving on to purulent infections, and again, kind of breaking it down to mild, moderate, and severe. And first, we'll talk about mild and moderate. Mild purulent infection, you can just do an incision and drainage of the abscess. Antibiotics are not necessarily required. My wife has this kind of distressing story about when she had her ER rotation when she was a PA student. And I guess an individual came in with an abscess on their anus, and she had to incise and drain it. And it was just horrifically painful. Because, you can't really numb it up because that's just probably more painful than just doing the drainage. This sounds completely awful. So I would not want this to happen to me.
Yeah, if I had to pick like my top 3 places to get an abscess, that would probably not be one of them.
And from how she described it, it was pretty significant. And I'm like, I don't think I would wait too long to seek medical attention if I had an abscess there,
Yeah.
So
I would also be real concerned about, which I mean, I know happens all the time, but I'm like, if I was like, hey, I have this horrible abscess in a location that is not ideal. Do you have anyone who's a student that can cut on
no,
me?
that's exactly what I say. I'm like, that's why I don't want to go to teaching hospitals. But she said, the doctor asked and the lady agreed. So it's not like they just surprised her with a student and, but it worked.
Yeah,
it worked out.
and I'm sure she did a great job. I'm just saying, I'm sure there's also some that would not do a great job.
Oh, sure. And I'm sure there's also some who wouldn't want the student to do it, which is very reasonable because I probably wouldn't want that either. But, doctor was there making sure it was all good. So,
yeah, that's cool.
Yeah, crazy. So that's mild. So you don't necessarily have to use antibiotics. Moderate infections, purulent infections may be associated with Staph aureus, might be MRSA, depending on the risk factors. Oral antibiotics can be used here. So you still want to do an incision and drainage of the abscess, plus you want empiric coverage. So orally, we're thinking doxycycline, Bactrim. If cultures show MSSA, so it's methicillin susceptible, we could de-escalate to like decloxacillin and cephalexin, being good stewards of our antimicrobials, as it were.
Yes. We always have to de-escalate. And how often that actually happens, hard to say.
Yeah, because in an oral situation, that means that you'd have to follow up on it and then prescribe something new, and then they'd have to pick it back up. And how often does that happen? Yeah,
that's exhausting.
Yeah, that sounds like work to me.
Yeah, that's a lot of work.
That's a lot of work.
All right, so Cole mentioned Bactrim, sulfamethoxazole, trimethoprim, the two ingredients in that drug. So it is a combination medication. So from the sulfamethoxazole side of things, you're stopping folic acid synthesis. You're inhibiting the dihydrofolic acid formation in the bacteria, and so you shut down that synthesis from that angle. You're also inhibiting dihydrofolic acid reduction to tetrahydrofolate, and so that folic acid pathway is shut down there too. So folic acid inhibition is the name of the game for Bactrim. Coverage-wise, we always kind of, at least in my mind, we always jump right to the gram positives. So MRSA being a big one, strep pneumo as well. But it also does have gram-negative coverage for some of the more common gram-negative bugs we see: Proteus, Klebsiella, Haemophilus influenza, E. coli, things like that. But because it has the MRSA coverage, we tend to save it for that type of infection, just to again be good stewards. It also has coverage for certain random bugs like Salmonella, Shigella, certain opportunistic pathogens. So it's definitely a very useful spectrum antibiotic. Side effect profile, GI side effects potentially, skin reactions are another fairly common, rash, things like that. Sulfa allergies are very common as well, just like penicillin allergies are. It can cause photosensitivity as well, especially if you've been on it for a few days. Increased serum potassium is a concern in some situations, especially if a patient is on multiple medications that can raise potassium levels, and you throw this on board on top of it. Obviously, there's that risk of hyperkalemia. They will go up. It also, because of how sulfonylureas work, and so if you think about like glipizide or something like that, they stimulate that insulin secretion in someone with diabetes. This has Bactrim has similar properties to something like a sulfonylurea, and so the risk of hypoglycemia seems kind of weird, but it is basically working almost like a sulfonylurea and causing the pancreas to release insulin. So somebody who is on insulin therapy or taking other medications that can cause hypoglycemia, that hypoglycemia risk tends to go up in those patients. Right. In fact, I had a patient one time in particular that it wasn't my patient. I think I was working at Walgreens at the time, but it was asking me about what could be causing his low blood sugars. And I'm pretty sure, if I remember correctly, he was on insulin and then also a sulfonylurea, which is just the best regimen.
It's fantastic.
But he's like, yeah, my sugars have been great. His A1C had been like a 6 something. Like he was not having any problems. And then he's like, all of a sudden my sugars are jumping up and all over the place, and I'm waking up with like in the 40s, and I have no idea what's going on. And we went back and looked at basically, the long story short, the only thing that had changed was him starting Bactrim from an urgent care place, like the same day that all the hypoglycemia started happening. But it was just interesting to see that side effect actually play out, and somebody who had a potential, dangerous situation with his sugar dropping in the 40s.
Yeah, no, that is, especially because an infection itself can make your sugars go wackadoodle, frequently high, right? So along with the Bactrim, I imagine that's why he was flying all over the place.
Yeah. So something to keep in mind with those.
Yeah, I don't think that's thought about too much. That's good. Doxycycline, like we mentioned, so it's a tetracycline antibiotic used very commonly. How does it work? It interferes with the bacterial protein synthesis by binding to the 30S ribosomal subunit. So it will result in a defective bacterial cell wall membrane. It has coverage such that it's used in a variety of infections, respiratory, tick-borne illnesses, you might have heard, atypicals, MRSA coverage, Vibrio species, also UTIs caused by VRE. Typically, it's not used in really young kids, less than 8 years old. It can, as well as for the similar reason, also not pregnancy or breastfeeding, because it can suppress bone growth. It may also permanently discolor teeth. There's been reports of that with tetracycline. Adverse effect-wise, pretty well tolerated, but GI upset, also skin reactions and photosensitivities. This is the one that people think about when they have to, or counseled to put on extra sunscreen while they're taking it, or at least one of them. You want to take it with food. That can help with the GI upset as well, but multivalent cations can chelate and inhibit absorption. So antacids, supplements, anything like that has a di or trivalent cation, you want to take 2 hours before or 6 hours after doxycycline.
Yep. Because your heartburn might go away, but your infection will remain.
Yeah, not great.
Yeah, that old saying.
That's an old saying.
It's an old pirate saying.
One of those core consult idioms.
Yeah, that everyone just cannot help themselves but repeat, or something like that. I know we were already past this section a little bit, but since I mentioned fluoroquinolones, like in levofloxacin as an alternative to beta-lactam when we were talking about non-purulent, I guess let's run through some review of fluoroquinolones too, just to make sure everyone's still that's all fresh in their head, because fluoroquinolones have a plethora of box warnings and other simple warnings to keep in mind, bunch of potential adverse effects. And so, whether we're going to use these or not is obviously a big question we need to be asking ourselves. And if there's a clinical reason we need to be going this route, then great. But fluoroquinolones have been kind of put more in the reserve for a lot of different types of infection now, just because of resistance and all the potential harm they can do. So from a box warning standpoint, they can increase the risk of tendon inflammation and rupture, which is definitely not a good one. I know 2 people personally that have actually had that happen to them while taking a fluoroquinolone, so that it's not just a textbook thing. And they have also been reported to cause peripheral neuropathy. Some of the episodes have been reported to last months, and some even as long as years after the medication was stopped. In some cases, they can lower the seizure threshold. There's been episodes of toxic psychosis that have been reported with fluoroquinolones. And then on top of all that, you have to worry about like QT prolongation, the highest risk being with moxifloxacin, but they all technically can cause that. They can affect the sugar in both the hypoglycemia route or the hyperglycemia. So, again, it's just basically causes this huge fluctuation in your blood sugar. But, elderly patients and whatnot, the hypoglycemia risk needs to be something we consider with these. Photosensitivity as well, musculoskeletal toxicity, skin reactions, all of those types of things, and much more as well. Obviously, using caution when we're giving patients fluoroquinolones, and then obviously also to making sure we counsel on the potential harms. And if you have a runner or something like that, making sure they take a break before they go sprinting off with a bunch of Levaquin in their system. Same thing like when Cole mentioned with the doxycycline, we do have to worry about the multivalent cation chelating reaction and inhibiting the absorption of the antibiotic. So if the patient is taking any type of antacid or anything like Cole mentioned, same thing, 2 hours before, 6 hours after with the fluoroquinolone is ideal to avoid that interaction. But they also, fluoroquinolones can increase the risk of, increase the serum concentration and the effects of, so not only the risk, but the effects of a few different medications. Sulfonylureas, insulins, again, going back to the fact that it has an impact on blood sugar, so you can increase the risk of hypoglycemia when you add a fluoroquinolone to that combo as well. And then warfarin can interact with fluoroquinolones, and then other drugs that prolong the QT interval would obviously have to be something that we are looking out for as well. If the patient does have multiple drugs that can prolong the QT interval, we probably would want to take a look at like the potassium, magnesium levels as well, just to make sure there's no additional risk factors for the patient having a torsades or something. And then, if the patient also has low potassium or magnesium on top of adding the fluoroquinolone with the QT prolongation risk, then that also increases the risk in and of itself. So if the patient's on diuretics, things like that, probably want to get at least a CMP to check their potassium and mag. Well, and you have to order magnesium separate. So
and if they're already taking so many kg, probably wouldn't be a bad idea to see what their interval is at that
Absolutely.
point, right?
Yeah.
Cool. So kind of lastly, before we get into the severe purulent infections, is linezolid. It's an oxazolidinone, I guess is how you say it. But it has coverage of MRSA, streptococci, enterococci, covers VRE as well, and you want to avoid it in patients with MRSA bacteremia. It binds to the 50S ribosomal subunit to cause inhibition of RNA-dependent protein synthesis. It has some things that are definitely good to be aware of and do come up regularly. One, it can decrease platelets. It can also decrease hemoglobin and white blood cell counts, which makes sense. It can also increase serotonin levels and blood pressure when it's used with other adrenergic drugs. So keep that in mind. Other side effects, it can potentially cause peripheral neuropathy as well as optic neuritis, all things to consider with linezolid.
Yeah. And it also has an oral formulation too, which is kind of unique for that type of a drug.
Yep.
So assuming the patient has, moderate a moderate purulent infection, so they're going to be treated, like Cole said, in the outpatient setting. We can go through all those different oral antibiotics that Cole had, and I just kind of went through. But just like we had that criteria for a severe infection, kind of like cut off, just like with a non-purulent, we also have that for the purulent infection as well. So very similar. If the patient has failed, incision and drainage plus antibiotics, at that point we would then classify that as severe. Immunocompromised patients should also be treated as if they have a severe infection, and then also the patients that meet that SIRS criteria, like Cole said, 2 or more of the patient either having a temperature greater than 38 degrees Celsius, pulse greater than 90 beats per minute, respiratory rate of greater than 24, or a white blood cell count of either less than 4,000 or greater than 12,000. If that's the case, then you kind of check those boxes, then you would classify the patient as having a severe purulent infection at that point.
Yep. You're also thinking that you need coverage for MRSA as well. So we're going to be using IV antibiotics. So you want to do an incision and drainage of the abscess plus IV antibiotics that cover MRSA. Kind of like we touched on, vancomycin, linezolid cover MRSA. Also telavancin, daptomycin, like we said, ceftaroline. And then if it comes back that it's methicillin susceptible, you can de-escalate you should de-escalate to nafcillin, cefazolin, clindamycin. Those are all good de-escalation options.
Yeah. Basically, instead of just memorizing the antibiotics, think about it in regard to, okay, if you know which of the IV formulations cover, MRSA, when we switch them to an outpatient setting, we're going to either de-escalate or at least, if nothing else, switch them to an outpatient available med. So if we're on vanc, we're not just going to keep them on vanc and keep them in the hospital the whole duration if we don't have to. So switching them to an oral agent, looking at a Bactrim or something like that, is an easy way to kind of think about that transition.
Yeah, logistics will probably prompt that to happen.
Yeah, for sure.
Because, they always want to get them discharged as soon as they can.
Yeah. So just to kind of go back through a couple more antibiotics, and then we'll summarize everything at the very end. But we have our lipoglycopeptides, and the one that Cole mentioned in particular, the telavancin, is one of those. There's also ortavancin and debavancin. I can't ever say that one at all. I should have just skipped it, huh? But that would have been good.
The D one. It's the D.
Yeah,
the D.
Yeah. It's like I had the first syllable out of my mouth. Like, why am I even trying? This is so
when in
dumb.
doubt, just say the brand name. That's what.
That's a good point. Dalvance. But these have pretty similar coverage to like vancomycin, except they do have some variable coverage to VRE, and so that added benefit to these. Adverse effects, infusion reactions, GI issues. Telavancin in particular has been known to cause like a metallic taste in the mouth, as well as increase in serum creatinine and reported foamy urine as well. So all of these are approved for SSTIs. Cost tends to obviously be a potential factor, and two of them are single dose regimens, so they're very convenient. But the cost, I think, with these is a big issue. They can falsely increase INR as well as APTT, and again, it's not causing an actual increase in the risk of bleeding. It's just making the labs look incorrect or out of range. And these are given IV as well.
Go ahead.
No, I was going to say we want to summarize all that again, but what were you going to say first? Go ahead.
I was just going to mention one of the relatively newer fluoroquinolones. You did go over a lot of fluoroquinolones, but there's one that you don't hear of as often, delafloxacin, which now it's been 7 years since its approval, but it was in 2017. And it's similar to a lot of fluoroquinolones. It has good activity against Staphylococcus like MRSA, also gram-negative bacteria, including Pseudomonas, and anaerobes like C. diff. And it's out there, but not one that you'd see as often as the others, I suppose.
Yeah, I feel like that's how I always keep that one straight in my mind is the only, like, the fluoroquinolone that actually covers like MRSA and not just like strep pneumo or something like that.
Right.
But the cost again with this one is pretty rough. I haven't seen it lately, but last time I checked, it was a lot more expensive than I thought it was.
And it's going to come with all the same concerns as the class.
Yeah. So, but it does cover MRSA. So if you do need to go with fluoroquinolone route, there is data in that drug in this patient population, basically comparing it to vancomycin plus aztreonam. So it seems to be like a potentially a good option if the patient has great insurance and all that.
Yeah.
And there's also a tetracycline that was approved back in 2018 that I personally, I don't think I've ever seen anybody on this, but omadacycline is the name of it. It has activity against Staph aureus, both resistant and susceptible isolates. It's got activity against strep species, Enterococcus, Klebsiella, and some others. And so it was compared directly to linezolid and was seen to be non-inferior, comparable results in both groups. So we threw those in at the end just to make sure you've at least seen those antibiotics. But those would be options for a patient who is getting discharged and or for whatever reason, and while they're in the hospital, those very commonly used antibiotics are not available or something. Then these are some alternatives that weren't listed on that algorithm.
Right.
But just to kind of summarize one more time, talking purulent infections, incision drainage for all these patients, and culture and sensitivity reports and stuff as well. That way, if we can hopefully de-escalate, when we find that it's not MRSA. Empirically, if the patient is going to be treated in the outpatient setting, mild, you don't necessarily need to use antibiotics. Moderate, you are going to use an MRSA covering antibiotic or that's taken orally so they can be discharged. So Bactrim or Doxy and then de-escalate if culture insensitivity report comes back with, susceptible Staph aureus or whatever. If it is considered severe, then you're escalating therapy to the IV formulations that have the same coverage. So vancomycin, daptomycin, linezolid, telavancin, ceftaroline is the 5th generation cephalosporin that covers MRSA, and then again de-escalating from there. So lots of potential options, and a lot of it's going to come down to what's on your hospital's formulary. But it's good to know what's are some potential choices.
Yeah, I agree.
Anything else with this? I know I just looked at the time. Like we're actually getting close.
We're almost at time. No, I think that's all I had.
Cool. Definitely make sure if you guys have been listening to these episodes for however many accredited episodes you've done, and you've never checked out Free CE, please give them a look. Just take a gander, and then if you don't like it, I'll never ask you again.
At least a gander.
Just a gander. Just see what you think. But in all seriousness, we're very grateful to them continuing to partner with us. And if you are a member, make sure that you get your 1 hour of continuing education credit for this episode. If you want more like structured, lecture material with PowerPoint slides and all that good stuff, check out patreon.com/coreconsultrx, and you can download the slide sets that go along with the video lectures, and there's a whole bunch of different disease state reviews on there. Make sure you check out pearls.com/coreconsultrx. You can download the free option of the Pearls Drug Info app and still get access to several charts and things like that, even though it's the free version. And then if you want to upgrade from there, you can get access to all of their content for a very reasonable price. They've been partnered with us for years now, I think, and so they've been great. They've grown tremendously since we first met with them. So check them out too. They're a great resource, and I definitely think it's going to be growing even more than it already has. But other than that, Cole, do you have any other things? One more time, where can people get your plugin?
Yeah, just Google MedSearch Chrome extension, or go to the Chrome web store for Chrome extensions, and it's called MedSearch, MED search.
Yes, y'all go check that out. If you like it, make sure you get yourself a copy so Cole can hurry up and retire.
Right. I'm so close.
All right. You're almost there, man. All right, everyone. Thanks for listening, and we'll see you guys on the next episode. Have a good night.